maximum time to talk. Okay, so first up, Matt Page from Monash will, one of the co-conveners, will give us a short overview of activities under BMG over the year.
Thanks, Julian. You can all see my slides?
Yeah.
Yep, great. So welcome everybody. And what I'll do in this session is just give a brief overview of the activities of the Bias Methods Group over the last year. And then we have three speakers, each giving a 10-minute presentation with 5 minutes for question and answer, and then wrapping up from Julian at the end. So this meeting, as you will realize, because you will have agreed already, is being recorded and it will be posted on the Bias Methods Group website in the coming weeks. And we very much welcome any questions and comments that you might have, which you can enter using the chat function, or you can raise your hand and one of us will unmute you so that you can ask your question. But please feel free to put questions there in the chat throughout. So who we are and where we're from, essentially the Bias Methods Group consists of 415 members worldwide. And this graph here, a picture of the countries shows the distributions of people in our membership, with primarily people coming from Canada, the UK, and the US. But we do seem to be in every continent. A quick look at that there, but hopefully we'd like to build our footprint even more over the coming year. In terms of the interaction we have at the moment, we have a mailing list, which includes 227 individuals, to which we send a newsletter twice a year. We also have around 2,500 people following us on Twitter. That is at the moment, whether we actually stay on Twitter or all join the Mastodon migration is something we'll consider in the coming weeks. We have had a look at the Bias Methods Group website itself. Has had quite a large number of page views this year, over 100,000, with 49 of those individual users accessing the resources on our website, which includes links to our newsletter, but also links to our tools and training materials. So do take a look at that website if you haven't already done so. So what we've been up to in the last 12 months, we've had 5 convener meetings, and we've delivered 2 newsletters giving you updates on our activities. And something we always like to do is keep people abreast of certain methodological papers that we think they might be interested in. And in addition to that, we've undergone quite a lot of training and development for our risk of bias tools. We've been developing some new tools and then contributing to other projects in the scope of the Bias Methods Group. So in terms of training, Cochrane has a set of online learning modules, each covering different steps of the systematic review process. And we recently contributed to a revision of the module on risk of bias assessment, incorporating the elements that are included within the Cochrane Handbook and any other more recent evidence that's been accrued in the last few years. We've also done our own workshops on risk of bias throughout the year. One that I wanted to highlight is was Tianjin Li invited us to Colorado to give a workshop on a range of risk of bias tools, including Rob2 and the Robin's Eye tool. And just want to show a photo because it's still so surreal to me, the notion that we were actually able to do in-person teaching finally after 2.5 years of long periods of lockdowns. And one thing we're able also to undertake during that workshop is something that I always missed, which was the silly photo for a workshop. So it was really good fun to convey risk of bias material to our audience, as well as having a good time along the way. In addition, we've been continuing to work on a range of tools. So the ROB-ME tool, standing for risk of bias due to missing evidence, the TACIT tool, which is a tool for assessing conflicts of interest in trials, both of which are in late stage development, nearly there for release, I'm optimistically going to say. And then in the middle of the year, the risk of bias in non-randomized studies of exposures tool was uploaded to Risk of Bias Info. So take a look at that if you're interested in looking at this sister tool to the already popular Robin's Eye tool. In addition, some other projects we've contributed to is at the moment there's an ongoing effort to update both the SPIRIT reporting guideline for protocols for reviews and the CONSORT 2010 reporting guidelines for reports of randomized trials, which several other conveners are part of the executive group. We think this is going to be a useful mechanism to help ensure that the reporting guidance that is delivered to trialists is somewhat in sync with the content of the risk of bias tools we use, so that we're essentially prompting users to convey the information that we would like to see when assessing risk of bias in trials. Also, we have a really exciting initiative led by Isabelle Boutron, the COVID NMA initiative, living network, living evidence synthesis of drug and non-pharmacological treatments for COVID-19, where members of the conveners have contributed to the development of training material and quality control for the ROB2 assessments for those trials to ensure that they are high quality assessments underpinning those syntheses. And so plans for 2023, what we will hope, I'm hoping that we see another 2 tools completed and ready to be rolled out to the community, along with continuing our implementation of our existing risk of bias tools, and contributing to these other programs of work in terms of the reporting guideline and COVID NMA initiative. So I will stop there and take any questions if you have any.
Thanks, Matt. Do we have any questions? Are we seeing any hands or chat messages? I don't. In case anyone's typing, I'll give it a few seconds. Okay, well, if there are no questions, we are in good time to move on to our first speaker, Dina Zaradka, who's at McMaster in Canada and has very kindly taken the time in the middle of the night to talk to us about preprints. So thank you, Dina.
Thank you. Are you able to see my screen all right? Yes, okay, I see some nods, so I'll assume everything is good. All right, well, thank you for the introduction. It's a pleasure to be here. I'll start with disclosures. I don't have any relevant disclosures, but I did author the study on which I'm presenting. So I do have a little bit of a vested intellectual interest. So traditionally, as we're all familiar, scientists communicate new scholarly research via published journal articles. And preprints represent an alternative method for the dissemination of scholarly work. So us as scientists may upload our manuscripts to preprint servers, examples of which are bioRxiv and medRxiv, after which we may or may not submit for publication in a peer-reviewed journal. So preprints are really manuscripts that have not yet undergone peer review. Researchers and evidence users have raised concerns that the traditional publication model is slow, peer review may not always improve the quality of manuscripts, journals impede dissemination due to paywalls and high publication fees, and that they encourage publication bias by prioritizing statistically significant or anomalous findings. And these are all issues that preprints may theoretically avoid. So during the COVID pandemic, the scientific community very enthusiastically adopted preprint servers to allow for the rapid dissemination of what could have been potentially life-saving research. And at one point, preprints actually accounted for approximately a third of all COVID research. Seminal COVID trials, for example, representing massive international collaborations like Recovery and Solidarity, all chose to report their results in preprints before subsequent publication in journals. Now, the medical community has been a little bit cautious about the adoption of preprints because they may contain important errors. So during the COVID pandemic, our group worked on a series of living reviews and meta-analyses addressing COVID therapeutics. And these living reviews essentially had a living synthesis of all trial evidence addressing drug therapies, antiviral antibodies, and cellular therapies and prophylaxis for COVID. So we capitalized on this data in order to explore the trustworthiness and impact of trial preprints during the COVID pandemic. So as part of the living reviews, we performed daily searches of COVID research databases and following training and calibration exercises to ensure sufficient agreement. Pairs of reviewers work independently and in duplicate to screen the titles and abstracts and the full text of records deemed eligible at the title and abstract screening stage, and then they extract data from the eligible trials. For this study, we asked the screening team to link preprints with their later publications, and we also asked the data collection team to document differences in key methods and results between the preprints and the publications. So our study included all the trial evidence available at the time on COVID therapeutics, which was a total of 356 trials, 101 of which were available as preprints, 181 as journal articles, and 74 first as preprints, and then they were subsequently published as journal articles. So we calculated the length of time between a preprint being posted on a server to its publication in a peer-reviewed journal, which is an indicator of the extent to which preprints may accelerate the dissemination of findings. So the median time from a preprint being posted on a preprint server to its eventual publication was approximately 6 months. Half of all preprints remained unpublished at 6 months, a third at 1 year, a length of time that we may consider to be unacceptable or too long for a health emergency like COVID. Now, bear in mind that these are all COVID trials, and journals expedited the publication of COVID research. For other areas, I anticipate the time to publication to be at least twice that of what we're seeing for COVID. So we compared the preprints of trials that were later published to their publication for discrepancies, and the idea was that important differences between the preprints and the later publications would suggest that preprints may not be trustworthy and the trial reports are actually undergoing important changes in the peer review process. We found that half of all trials had one or more discrepancies in the reporting of key methods and results, which was concerning, but the discrepancies didn't seem that important. For example, the Recovery dexamethasone trial reported slightly different results for mortality and mechanical ventilation between the preprint and the publication, most likely not because of an error in the preprint, but because of events that were accumulating in the trial from when the preprint was posted to when the article was actually published. This figure shows differences in results between the preprints in purple and the later publications in white for trials that reported on mortality and mechanical ventilation. And as you can see, the magnitude and precision of results were nearly identical between the preprints and the publications. Now, while we didn't find compelling evidence of important differences between preprints and their later publications, it's important to be mindful that preprints that are subsequently published may really represent the most trustworthy or the highest quality preprints. Also, a reminder that these are clinical trials and not observational studies or systematic reviews. So when investigators analyze data from randomized trials, they typically operate under strict standards like registering protocols and statistical analysis plans before recruiting patients and collecting data. So important methodological decisions like whether to blind patients and healthcare providers and the choice of primary outcomes can't really be modified upon trial completion. There is, however, more flexibility for observational studies. When investigators perform observational studies, they're not really obligated to register protocols or analysis plans. They may modify critical aspects of their methods, like their analytic approach, during peer review, which may give rise to differences between preprints and publications. Also, bear in mind that we only consider discrepancies in key methods and results. There's potential for spin and misinterpretation that may be corrected during peer review, and there's now evidence that that does occur. So we don't make decisions based on individual trials, but rather the totality of evidence. And the Living COVID Systematic Review informed the WHO COVID guideline, which is a clinical practice guideline addressing drugs for COVID. In making recommendations for COVID drugs, a WHO guideline considered evidence from both preprints and publications. So a panel of methodologists, physicians, ethicists, public health practitioners, and patients with lived experience of COVID reviewed the evidence, considered benefits and harms and other factors like feasibility, acceptability, and equity in order to generate recommendations. We wanted to understand how preprints have contributed to clinical practice guideline recommendations and whether recommendations may have been different if evidence from preprints weren't considered. So to address this issue, we selected 8 therapeutics that had been addressed by the Living WHO COVID guideline and performed meta-analyses, including and excluding evidence from preprints at 1, 3, and 6 months after trial data first became available, addressing that therapeutic, and also at the most recent time point. We then considered whether the Living WHO COVID guideline may have made different recommendations if it had not considered evidence from preprints. So we performed 120 meta-analyses in total, 60 of which included preprints and 60 of which excluded preprints. Except for 2 cases, meta-analyses, including and excluding evidence from preprints, actually produced point estimates that were consistent as to whether the therapeutics indicated benefit, no appreciable effect, or harm. But while the point estimates were generally consistent, there were 9 meta-analyses for which including versus excluding preprints produced different ratings of the certainty of evidence. For example, consider the case of IL-6 receptor blockers, tocilizumab and sarilumab that are now part of standard care for COVID. At 6 months after trial data first became available, when preprints were excluded, we found low certainty evidence that IL-6 receptor blockers may reduce mortality. And in such a situation, the guideline panel may not necessarily make a recommendation to use IL-6 receptor blockers, but conversely, when we considered evidence from preprints, we found moderate certainty evidence that IL-6 receptor blockers probably reduce mortality. And in such a situation, a guideline panel would probably make a recommendation for IL-6 receptor blockers. In this case, considering evidence from preprints may have importantly accelerated the time to the incorporation of IL-6 receptor blockers as part of standard care, which may have been potentially life-saving for some patients. So findings from this study have implications for systematic reviewers and guideline developers deciding whether to consider evidence from preprints in systematic reviews, for evidence users who are generally concerned about the credibility of preprint reports, and for trialists who are interested in identifying venues for the dissemination of their findings. So what can we take away? I think preprints represent a promising approach for the dissemination of randomized trials. And I don't mean that we should do away with peer review and journals. I think that preprints can play a promising role in the dissemination of information, especially in the context of health emergencies. But I think sometimes in our pursuit of trustworthy evidence, sometimes we fail to acknowledge some of the problems with journal publications, one of the largest being the potential for perpetuating publication bias or repressing minority opinions that may not be aligned with the dominant opinion in a particular field. There are, of course, also risks to using preprints. When I speak to people who are wary of preprints, they often have concerns about data integrity and data fabrication. But we know that peer reviewers and journal editors seldom have access to primary data. So I think it's a little misguided for us to sort of expect publication to address these issues. Case in point, during the pandemic, the New England Journal of Medicine, a highly respected journal, very high editorial standards, published a study describing fraudulent data. I think with the number of available journals, the rise of predatory journals, the fact that peer reviewers seldom have access to primary data, coupled with this evidence, we can agree that publication is not really a perfect indicator for trial trustworthiness. To play devil's advocate, one may argue that publication in a peer-reviewed journal may be misleading to lay readers who may put too much faith or confidence in the peer review process. Overall, I'm sort of excited to see the role that preprints will play in the future of evidence synthesis.
Thank you very much, Dana. A really, really interesting talk around. I think a lot of us have been concerned or interested in the role of preprints in systematic reviews. I see the first hand up from Matt Page.
Sorry, that was a clap.
Oh,
I don't actually have a question.
I'm sorry. It's a hand waving. That's a clap from Nagas and Laura and lots of people. Okay. So, well done. Do we have any questions then? Well, I suppose I could start if there aren't any more at this time. You expressed some concern, I think, over what was I saying? Preprints versus preprints that are not published. You expressed a possible concern that maybe they are less strong than the ones that you identified that you could compare with the published ones. So I was wondering what your reflections are, whether it's better to use those prints rather than nothing. Presumably, it's a lot better to use some information than not. So how would you recommend people proceed?
Exactly, and that was our thought, and we saw that when we did the meta-analyses where we included and excluded evidence from preprints. There were cases in which we may have made different decisions if we were blind to the preprints. Now, of course, I'll say that COVID was a unique situation. We had very trusted trialists that were using preprint servers, and that may not be the case outside of COVID. For example, Recovery, all of their trials came out as preprints. So a lot of our data was sort of dominated by Recovery and RemapCap and so on and so forth. So the situation might be a little bit different outside of COVID, but yeah, some data is better than no data. And of course, we acknowledge there's selection bias when we're looking at the discrepancies between the preprints and the publications.
Great, yes. Question from Sue Mallet.
Oh, hi, Dana. That was great talk. That was really interesting. So do we have any evidence of like large scale dumping of junk onto these preprint servers, or are there do their approval processes stop that, you know?
So I can only speak about our own experiences when we were doing the searches for preprints, and we didn't find really a dumping of, untrustworthy trials or like trials that we couldn't interpret and so on and so forth. What I didn't present is that we also looked at retractions to see if there were differences in retraction rates. We found 3 retracted publications and 1 retracted preprint, which may sort of give you an idea of, the proportion of the trials that later on receive attention that may not be trustworthy. But of course, you could also argue, well, preprints are probably less likely to attract as much attention as publications. Preprint servers may not have editorial standards and so on and so forth for retraction. And that's all true. We didn't notice any, big problematic dumping of data onto preprint servers. But I suspect that if we were looking at observational studies, we may have seen more fishy things.
Thank you.
Thank you. Well, I think we better move on to our second speaker. Thank you, Dana. Thank you so much for doing that in the middle of the night. Really appreciate it. So Raju Kanukula, who's based at Monash in Australia, is going to give us a talk about bias due to selective inclusion of study effect estimates. Are you all ready, Raju? Yeah.
Can you see my slides, Julian?
You need to put it in presenter mode, Raju. Go to display settings.
Okay. So,
And then, yep.
Yeah.
All good now.
okay. So I'm Raju Kanukla, PhD student from Monash University. Today I'm going to talk on the topic, a comparison of two studies investigating bias due to selective inclusion of study effect estimates in meta-analysis. First of all, I would like to thank my supervisors, Matthew Page and Jonah McKenzie, and my collaborators and also colleagues from Methods in Evidence Synthesis Unit from School of Public Health and Preventive Medicine. First of all, I would like to start by introducing the terms multiplicity and bias due to selective inclusion using an example. So in this slide, you can see that there are 5 studies included in a meta-analysis, and they have reported multiple effect estimates. You can see study 1 to 5, there are multiple effect estimates. This means there is multiplicity existed in the included studies. So let us suppose if the systematic reviewers who conducted that particular systematic review, if they pre-specified that the results adjusted for most variables would be considered in the meta-analysis. So in this example, you can see that the meta-analytic effect estimate and its confidence intervals that suggest that the exposure may be associated with the negligible risk of the outcome. So the diamond, you can see that there is that is lying on the line of no effect. And on the other hand, if you see the black lines as well as the squares here, in this case, if the systematic reviewers did not pre-specify a decision rule to select an effect estimate when there were multiple effect estimates were available from a study, and instead they have chosen effect estimates that were showing largest decreased risk. So in this case, you can see that the effect estimate and the 95% confidence interval leads to an interpretation that is different than the previous case. So based on this we can say that there is a bias due to selective inclusion because there is a difference between two effect estimates obtained with the pre-specified decision rule and without pre-specification of decision rules and selecting results into the meta-analysis. So generally, when systematic reviewers selectively include effect estimates based on the nature and direction of the results, there is a potential to bias the meta-analysis results. So as you can see here. So this issue leads me to the objectives of today's presentation. And the objectives of my today's presentation is, in this presentation, I'm going to summarize the results of 2 meta-research studies which were published by myself and my supervisors. Those were aimed to explore whether there was evidence that systematic reviewers selectively include effect estimates in their meta-analysis. If so, what is the impact of any selective inclusion is on the meta-analytic effect estimates? So these 2 meta-research studies were taken by my supervisors and myself, which were published in 2016. And so these two meta-research studies considered different systematic reviews from different clinical domains. However, they have used similar methodologies, and also the systematic reviews, if you see, considered by Page et al., they have considered outcomes types of continuous outcomes, and those 2 systematic reviews were published in different time periods. And also the included systematic reviews are having different types of study designs. Come to the data collection. From systematic reviews and their protocols, we have captured information related to the objectives, PICOs, and decision rules if they have pre-specified. So we have collected all the effect estimates from all the studies in case there was no decision rules pre-specified. For example, in this case, you can see for this meta-analysis, the criteria was healthy population and the exposure was Mediterranean dietary patterns, and the outcome was risk of prostate cancer. So, however, in this review, the systematic reviewers did not pre-specify which results were eligible when multiple effect estimates were encountered. So let us take one example, one study as an example, which was included in the previous meta-analysis. So if you see the results table of Jalil Piran 2018 study, there were 4 effect estimates were reported in this table, and those are related to the risk of prostate cancer in relation to the Mediterranean diet patterns. As there were no decision rules pre-specified regarding the which results to select, we have captured all these 4 effect estimates. And to quantify the bias due to selective inclusion, we have used potential bias index, which was developed by my supervisors and Professor Andrew Forbes. This PBI index is based on ordering the effect estimates in each study based on their magnitude and direction of effect estimates. And then we determine the position within that order where the effect estimate, which is included in the meta-analysis, sits. So here you can see interpretation of the potential bias index. The potential bias index values ranges between 0 to 1. And the potential bias index values 0 means the effect estimates least favorable to the intervention group are always selected. And the PBI value of 0 means the effect estimates are selected using a process consistent with the random selection, is that they are randomly selected into the meta-analysis. And PBI 1 means the effect estimates most favorable to the intervention group are always selected. So we have also generated all possible meta-analytic effect estimates with the available effect estimates we have captured from the included studies. This helps us in identifying, in assessing the impact of selective inclusion on meta-analytic effect estimates. So if you see here, there were 3 trials included in a meta-analysis, and these 3 trials reported 5 effect estimate. Trial 1 reported 2, and trial 2 reported 2, and trial 3 report only 1 effect estimate. So by considering all these 5 effect estimates, we can possibly compute 4 effect estimates. So which are 4 meta-analytic effect estimates you can see here. So coming to the results, Page et al. Study considered systematic reviews of multiple clinical areas, and they have only considered continuous outcomes. On the other hand, my study considered only reviews of nutrition research and considered both continuous as well as non-continuous outcomes. However, these 2 studies are having similar number of meta-analysis and also number of studies included in the meta-analysis, and also number of studies with multiplicity and number of eligible effect estimates available for each study. So this is the forest plot depicting PBI values and 95% confidence interval of both studies. So you can see 0.57 PBI of 0.57 from Page et al. And 0.49 from Kanukla et al. And the combined PBI estimate and 95% confidence interval indicates that the effect estimate was selected under a process consistent with the random selection. So this is a graph indicating here about impact of selective inclusion. So I will explain in detail about what is meant by possible meta-analytic effect estimates and median meta-analytic effect estimates and index meta-analytic effect estimate. So in this slide on the review height, which I highlighted, you can see there the gray dots indicates the number of possible meta-analytic effect estimates we have calculated based on the available effect estimates. And their range is between -0.3 to -0.6. And the blue dot indicates median meta-analytic effect estimate. This is we calculated based on all the possible meta-analytic effect estimates. And the red dot indicates index meta-analytic effect estimate, which is reported by systematic reviewers. And the difference between median meta-analytic effect estimate and index meta-analytic effect estimate indicates that there is no significant difference. This means there is no impact of any potential selective inclusion on the meta-analytic effect estimate. And we have also observed similar results of patterns in my study as well, even though we have considered different different clinical area, also considered different outcome types, and also considered different study designs for this meta-research study. To conclude, despite this, we would like to conclude there is no clear evidence that systematic reviewers selectively include effect estimates in both these meta-research studies. Despite this, we would like to recommend systematic reviewers to report methods to select results when they were encountered multiple effect estimates from the included studies. So this helps systematic reviewers as well as readers to verify and reproduce results as well as assess the risk of selective inclusion. So finally, based on the findings from these two studies, and also as there is no evidence existed on the bias due to selective inclusion, I would like to pose a question to all the attendees here. And my question is, as systematic reviewers and users of systematic reviews, do we need to be concerned about a risk of selective inclusion of results in the meta-analysis?
Thank you very much, Raju.
Yeah,
Really
thank you.
interesting. Very interesting. I could spot that, so it's a clap, isn't it? I'm learning. I wonder if there are any questions for Raju. So your work reminds me of something that a PhD student Richard Tendell did some years ago. Have you seen a paper in the BMJ where it wasn't about reported effect estimates, but she got a group of us, locked us in rooms in just outside of Copenhagen to extract data and extract as many different, it's pretty much the same thing here. We're extracting all the effect estimate. Well, we asked us to extract one effect estimate from each study according to a pre-specified protocol and to see which ones we all extracted, 12 of us in different rooms. And there are some plots much like yours that look at distribution of meta-analyses that could have been obtained by different combinations of people. Anyway, it's a bit different from yours, but it might be interesting for you to look at. I don't see any questions in the chat or any hands up, so thank you again. And I guess we'll move on to our last speaker, Emma Sydenham in London School of Hygiene and Tropical Medicine, going to talk to us about a tool to look at research integrity. Thanks, Emma. Emma?
Yes, I'm here. Do you need to, how do I share the screen? Here we go, share screen.
Yeah.
Okay, there we go.
Great.
That worked?
I am hoping it'll come up in presenter mode. Hasn't yet.
It says I'm says I'm screen sharing.
Yeah. Have you put this presentation into presentation mode?
Yes, I have.
Oh, well, it's not showing for us, but if you can get rid of the list of slides on the left, then hopefully it'll be big enough rather than faff around. Can you slide the left-hand tab?
Yeah, because that's
We're just seeing your PowerPoint screen. Not
do
in,
this. Oh, I can do stop sharing.
I think it was. Someone tell me if I'm wrong. I think it's probably good enough if you do it in PowerPoint. If we can't get presentation mode to work.
Sorry, should I hide self view?
Well, if you kick off the PowerPoint show, and
Which I have done.
then share screen and try and find the window showing the show. Just go, just do what you did before. That'll be okay.
I'm sorry.
Is it not working?
Okay, how is that?
Just go with that. It's okay.
Okay. Sorry about that. My presentation is about a new tool to guide the selection of studies in secondary research, whether it be a systematic review, mathematical model, or clinical guideline. It's also suitable for assessing the quality of a study prior to using the effect estimate for calculating a sample size for future research. It's a research and integrity assessment tool, but it has multiple uses. So this presentation consists of screenshots of referenced materials from the publication describing the tool. So what we're calling the Research Integrity Assessment Tool for RCTs and evidence synthesis was approved by Cochrane's Research Integrity Department, and it is currently in the consultation and quality assurance stage prior to submission to the methods executive and the scientific committee. So please do contact me with any comments, as we're grateful to receive feedback at this time while we develop the tool. So the reviews published by Cochrane are the gold standard in evidence synthesis, and the organization's editorial policies reflect the gold standard in regulation. For example, the terms and conditions of RevMan-Web explicitly state that only data from lawfully conducted research should be entered into RevMan-Web. It is also included in the standard Department of Health contract for research commissioned in the UK that only lawfully conducted data be used. But the issue has been that among systematic reviewers, there often isn't very much awareness as to what is lawfully conducted research and what is not. There is also now Cochrane-wide editorial policy on problematic studies, which explicitly defines how review authors should seek to identify and handle studies which fall short of the gold standard in trial reporting and conduct.
Emma, can I just ask, are you still on the title slide?
Yes,
Okay, good.
I'm just
Just checking that you weren't moving a presentation that we can't see.
Nope. So now I've advanced to the problematic studies slide. Okay. So this is just a screenshot of the Cochrane editorial policy on problematic studies. I'm just wanting to make awareness that this exists because it isn't included in the handbook. It's an editorial policy. So the problem is that a considerable amount of published research has not been done or reported according to the gold standard expected by WHO. This research integrity tool and the accompanying guidance is intended to support review authors and also provide a framework for teaching people who are new to evidence synthesis research. Another issue I'd like to mention is that sometimes when evidence synthesis work is commissioned, the commissioning organization may require the authorship team to organize indemnity insurance for the work. For people new to the field, this indemnity insurance is to insure against the risk of a payout from a class action lawsuit brought by patients or people who might have been harmed by the recommendations of the guideline on which the evidence synthesis is based. So by using this research integrity tool, which helps to ensure the legality and validity of the data underpinning the work, authors of evidence synthesis can meet the terms of the indemnity insurance and also deliver work with a high degree of transparency, so that it is simple for others to check the due diligence that has already been performed on the trial data. It is unfortunate that it is necessary to have to perform due diligence at the point of conducting secondary research, but it is necessary. So the research integrity tool, which is described in this publication, is available for download as an Excel file on the Zenodo platform. This is just a little snip of it. And the tool should be completed as a part of the study selection process and then published alongside the review. And an example of this are the 2 reviews which have already included this tool, which is ivermectin for prevention and treatment of COVID-19. And you see they have reported the selection of studies, the inclusion criteria, then the research integrity screening, and then they go on through the other sections of the review. And also this review by some of the same authors, where they also include the tool as an appendix in the review, in addition to describing its use in the selection of studies section. And then they also have separately published the Excel file. So I'm just going to briefly describe the tool, but I wanted to be clear that this tool is only suitable for use where the studies were fairly recently conducted and where they should have been registered in a trials registry. So this tool is not suitable for trials done in the 1960s or even the 1990s. And for those trials, I would suggest looking at a review of methods for examining the conduct of research. And in addition, I invite members of the research community to develop their own research integrity tool for their review. So for the tool that I am describing here, it is suitable for recently conducted studies where the intervention is classified as an investigational medicinal product and therefore falls under the National Clinical Trials Regulations. So the first item of the tool is whether the study has already been retracted, in which case the study should not be included in the review. If there is a published expression of concern, the study should be held in awaiting assessment, excluded from the review, or included depending on the nature of the issue raised in the published expression of concern. And you should note that in Cochrane reviews, there's an awaiting assessment category, while non-Cochrane reviews may not have this category. The awaiting assessment category is a place to hold the study if the review will be published prior to the review authors obtaining an answer to queries they may have about the expression of concern. The second item is prospective trial registration. The gold standard in the conduct of clinical trials and the expectation of WHO in this publication is that trials are submitted for registration before enrollment of the first person. An important element in the trial registration process is independent confirmation of a trial's existence. This means that the chances that a registered trial is a total fabrication is lower than an unregistered trial. Unfortunately, trial registration is not sufficient to assure the quality and validity of a study, so additional criteria need to be assessed when performing due diligence prior to using the study data. So ethics committee approval. In order for a study to be included in a review, we need to have the name of the ethics committee, the approval number, and evidence that the study incorporated written informed consent. Please note that if this tool were used, for example, on research on unconscious patients, and of course, written informed consent of a family member or legal representative of the patient would be acceptable according to the Declaration of Helsinki. A current challenge in identifying the national recognition of every research ethics committee, and I would like to point out that for India, there is a list, and we hope that in the future, other countries will publish a resource such as this. The domain author group examines the plausibility of authorship and can be helpful in identifying publications that may in fact be plagiarized from other research. For example, if the text of the manuscript is very similar to another publication, but the names of the authors and the study location is different. Likewise, for methods assessment, if a study is reported as a randomized trial in the title, but lacks any further description of the randomization procedures, the study would be held back from inclusion in the review until more information is received from another source. The final domain is results where a variety of considerations are put forward to assess the validity of the results prior to including the study in the review, such as calculation errors, implausible treatment benefits, or implausible numbers of patients with the condition recruited in the time frame of the study. So some of the research integrity assessments require subject or knowledge of statistical analysis, but both should be available to an evidence synthesis author team that has been commissioned to complete the work. And only trials that pass the research integrity assessment tool should be included into the review, where they later go on to have the risk of bias tool assessment. So finally, I hope that the next time you work on a review, that you consider using a research integrity tool to guide the selection of studies, whether it be this tool or one of the others available, such as the reappraised checklist or the Cochrane Pregnancy and Childbirth Trustworthiness Screening Tool. Or we encourage you to create and publish a new tool, as there are currently an insufficient number of tools available and used. I would like to acknowledge the authors of the two reviews which have incorporated the tool for which it was actually developed, and the funders of those reviews, and which also funded the latest update. Thank you very much.
Thank you, Emma. And thank you in particular for keeping to time. So we've got a little bit of time if there are questions or comments. You're welcome to close your presentation. Thank you. So we can see everybody. I see it was published just a few weeks ago in Research Synthesis Methods. I haven't read it myself, but looking just at the criteria quickly on the screen there, to what extent are they, do you think, assessing the credibility of the trial rather than the report of the trial? I see some elements about whether randomization was explained, you mentioned. So if it's only a conference abstract, does that mean that it's not credible evidence, or that just as a report that we I'm not quite sure what the relationship is between assessing studies and reports of studies.
Yes, so I mean, essentially it does both. Because we're looking at the prospective trial registration, if it were an abstract or a preprint, that would be fine, so long as we have that trial registration number and it was a prospectively registered trial.
Okay. Miranda Compston, you've got a question?
Hi, Emma. Thank you for that. I'm sure you won't be shocked to know that the idea of excluding unregistered studies makes me really nervous. I'm sure I'm not the first person to have raised that issue. I think it's particularly because I'm coming from often looking at public health research and non-randomized studies. So I'm just curious about if you can tell us anything more about the kind of underlying rationale for that, I guess, in terms of like how strong is the evidence base for what we might be losing by excluding those studies, you know, geographically, as you mentioned, time, but you know, I'm interested to know more about that.
Okay, this is not the right tool for a non-randomized, you know, for the studies that you're thinking of. This is not the right tool, and this is why I say we need more tools. This is a tool that is suitable for recently conducted trials where the trial falls under the regulatory framework of an investigational medicinal product. So in pretty much every country in the world, the legislation is pretty clear that prospective trial registration is expected. And so if that is missing, you know, maybe that's a red flag. That's what this tool actually captures, is it draws the guillotine at the prospective trial registration mark, so that you're just looking at the cohort, you know, that were, what shall we say, more likely to have been done according to the regulations.
Okay. I see a question in the chat from David Noonan. Are you able to speak, or would you like me to read it out?
if you could read it out, I'm on the train. I don't want to disrupt everyone.
Okay, I see it says you're on your iPhone. So the question, Emma, is what or which elements of data integrity does the tool cover?
Okay, so
So it says data integrity. I don't know whether the emphasis should be on data integrity.
data integrity. Okay, so first of all, it looks at sorry, I see you're on the train. So the first criteria, if there has been a retraction or an expression of concern issued already. So we're making sure that there hasn't been a concern raised elsewhere previously. And then looking at the trial registration element, and one of the markers of data integrity, I mean, if you look at the requirements for trial registration, looking at the trial registry platform slide, the trial registry does independent confirmation of a trial's existence as a prerequisite for the trial registration, in addition to confirming the trial sponsor, many different elements. So if a trial of an IMP, a recently conducted trial, if it wasn't registered, then we're missing out on so many elements which have embedded in this evidence ecosystem many checks and balances that ensure data integrity. So I would recommend having a look at the WHO 2018 requirements for registering a trial. Then the tool also has like a framework for the plausibility of the results, and it references a number of methods that can be used to examine the integrity of the data as well.
Thank you very much. I hope we've got time for probably one more from Martin Ringston. You've got a hand up.
Oh, yes, thanks. And thanks, Emma, for a good presentation. It's something we discussed within our author team yesterday, a big discussion. This is very, very relevant. And my question that arose from that discussion is, what would be the impact of implementing this instrument? Like, how many trials would be removed, and what would be like the impact of removing a large chunk of the evidence? Has that been explored yet?
Try and keep it brief.
I mean, sometimes this is more of a philosophical or even a practical or a legal issue. Who has commissioned this review and how is it going to be used? If a review is being commissioned by a national government in order to become the basis of a public health law, then the use of the data is a fundamentally different consideration than a review where you're trying to find everything. You really have to be, you really have to have done your due diligence on the trial, legal due diligence, make sure that these trials that are included really exist and that they are valid before you use it in the review. So sure, the objective isn't necessarily to find and use all of the data. The objective in this case, if the review will be used as the basis for a law or for public health guidance on a national basis, is validity.
Okay, thank you very much, Richard. We're very slightly over time there, so I'll bring things to a close. I didn't have anything I wanted to say particularly to wrap up, so I've let things carry on. Thank you very much to our three speakers. As the Biospecialists Group, please do get in touch with us if you've got anything you want to talk to us about, any interesting work you're working on, pointers to papers that you think would be of interest to the membership. So you can do it via Camilla. Should be easy to find via the Cochrane website or any of the four conveners. So thank you very much for joining us at the meeting. We wish you the enjoyable rest of your day, however long that may be. See you soon.